The next section of the Hypertrophic Cardiomyopathy Clinical Practice Update revolves around diagnostic testing. The practical tips suggest that transthoracic echocardiography should be done at diagnosis and periodically thereafter, every 1 to 2 years. Assessment includes that of maximal wall thickness. Echo reports the pattern and distribution of LV hypertrophy along with the magnitude of maximal wall thickness at end diastole and should be assessed in all LV segments. Measurement should be conducted perpendicular to the LV cavity while avoiding trabeculations, sigmoid septum, and papillary muscles. Pap muscle abnormalities are common in patients with HCM and might have implications for surgical planning. The presence of an apical aneurysm should be reported because of the potential implications on arrhythmogenic and thromboembolic risk, including consideration of oral anticoagulation. In terms of systolic function, hyperdynamic contraction is the hallmark of HCM, especially early in its natural history. Therefore, even an ejection fraction of 50 to 55% might represent early impairment of ventricular function. Systolic dysfunction is defined as an LVEF less than 50% and represents a risk factor for sudden cardiac death and heart failure. Longitudinal strain imaging might help differentiate HCM from other types of cardiomyopathies such as amyloid and Fabry disease and might provide incremental risk stratification. Strain correlates with the degree of hypertrophy and the extent of delayed gadolinium enhancement seen in MRI imaging. Obstruction is present or develops over time in more than 60% of patients with HCM. It can be the result or combination of septal hypertrophy with narrowing of the outflow tract, anterior malposition of the papillary muscles, systolic anterior motion of the mitral valve, and intrinsic abnormalities of the mitral leaflets. It is defined by peak instantaneous LVOT gradient greater than or equal to 30 millimeters mercury, either spontaneously at rest or provoked. Because LVOT obstruction is dynamic, various provocative maneuvers might be required to unmask obstruction, as listed here. Regarding SAM, contact of the anterior mitral leaflet with the septum creates failure of cooptation with the posterior leaflet that results in posteriorly directed MR, predominantly during mid to late systole. In some cases, non-posteriorly directed MR can still be related to SAM because of differences in leaflet geometry that alter the direction of the jet, either centrally or anteriorly. However, suspicion of intrinsic mitral valve disease should be raised when the MR is not directed posteriorly. In terms of diastolic dysfunction, abnormal relaxation and elevated LV filling pressures are a major component of the pathophysiology of HCM, resulting from myocardial hypertrophy with reduction in chamber compliance, delayed relaxation, ischemia, and myocardial fibrosis. This will often result in symptomatic heart failure and/or reduced exercise tolerance in patients with or without obstruction. However, estimation of diastolic dysfunction with usual echo parameters, such as transmitral flow velocities and tissue Doppler imaging, often results in modest correlation with LV and diastolic pressure. Comprehensive diastolic evaluation in HCM is often necessary, including EDA ratio, left atrial volume index, pulmonary vein atrial reversal velocity, and tricuspid peak velocity. Exercise stress echocardiography may be conducted with an upright treadmill preferably or supine bicycle as an alternative. The search for gradient should be exhaustive, particularly when the patient's description of symptoms is strongly suggestive of obstruction. If the goal is to achieve the highest success of showing someone has obstructive physiology, then the patient should abstain from medications such as disopyramide, beta blockers, and calcium channel blockers for 48 hours before the study. On rare occasions, it might be worth considering postprandial exercise testing because the associated Planck-like dilatation and increased cardiac output might unmask occult gradient. Moving on to cardiac magnetic resonance. The role of CMR has continued to evolve in patients with HCM for diagnosis and risk stratification. CMR is important in the assessment of resting LVOT gradient, mitral valve abnormalities, including quantification of mitral insufficiency, leaflet elongation or prolapse, apical papillary muscle displacement, etc. It's also important for late gadolinium enhancement in terms of its presence and quantification, also for microvascular disease, as per stress perfusion protocols, and for planning of septal intervention procedures. LV morphology, wall thickness, and mitral valve characteristics might also be helpful in determining the type of septal reduction therapy, such as myectomy versus alcohol septal ablation, and for planning the procedure itself. Ventricular volumes and left ventricular ejection fraction are also useful to identify patients with adverse LV remodeling at risk for end-stage heart failure. CMR imaging evaluation has become an important component of sudden cardiac death risk prediction in patients with HCM, and a number of morphological factors have been integrated into practice guidelines. Specifically, extensive LGE, comprising greater than or equal to 15% of LV mass, is considered a sudden cardiac death risk marker to consider prophylactic implantable cardiac defibrillator implantation.